Hello, class. You have made it to week 15, the last week of content for OCC 6019. I really hope you enjoyed last week's lecture and lab on burn with Gina. I can't wait to hear how it went and your guys' thoughts on burn in general. It's definitely a specific and niche area, but there's a lot, as you can tell, there's a lot to explore and a lot of research that still needs to be done to help that patient population. So for week 15, we are focusing on transplantation. I wasn't able to get through it all in week 13. We're going to do pain management and fundamentals of pharmacology for OT. So let's get started with transplantation. Transplantation is the process of transferring tissue from its original position to a new position. The survival rates and quality of life for transplant recipients has improved with advancements in surgical technique, preoperative and postoperative care, organ preservation, immunosuppression therapy, new technologies, and better candidate selection. Occupational therapists will work with patients before and after their transplant surgery. Overall, the goals are to increase function, strength, and participation in daily activities of living. The goals of pre-transplant rehabilitation is the improvement or maintenance of functional abilities and endurance while the candidate awaits transplantation. You want to keep them as strong as possible before they get their surgery. The goals post-transplant rehabilitation is to increase endurance and engage in formally preferred occupations. You want to get them back as closely as possible to their prior level of function. Organ procurement and allocation. Transplantation is a process, not just a surgical procedure. Success is determined by adherence to medications, diet, therapy plans, and family support. UNOS, which is the United Network for Organ Sharing, manages the national transplant waiting lists and is a thorough database of donor organs that can be matched with potential candidates. UNOS runs the OPTN, Organ Procurement and Transplant Network, which is a national registry of organ matching and policymaking. Death is determined when the heart stops beating or when the brain stops functioning. Cadaveric donors can be people who are brain dead even though their hearts and lungs may still be functioning with mechanical ventilation, cardiopulmonary bypass, or both. Once a donor has been identified, organs cannot be recovered without the donor's presumed consent. Considerations include candidate blood type, height, weight, and geographic distance. Transplant centers have 1 hour to decide whether they will accept the donor organ for their patient before it's offered to another center. Types of transplants. Single organ transplantation includes the heart, lungs, kidneys, pancreas, liver, thymus, and intestines. They can be single organ or multi-organ procedures. Corneas, eyes, heart valves, skin, veins, bones, ligaments, and tendons can be transplanted. Hematopoietic transplantation is transplantation of bone marrow and peripheral blood stem cells. I apologize for my pronunciation. Donor organs can come from deceased or living donors. Living donors have been used for kidney, liver, lung, and stem cell transplantation. The liver is the only organ that can regenerate itself. Donors must match the recipient through ABO blood typing and tissue typing. Criteria for organ donation. So the criteria for living donors includes being at least 18 years of age, in good mental and physical health, free from cancer, diabetes, high blood pressure, hepatitis, HIV, or other organ-specific diseases. Donors must match the recipient through ABO blood typing and tissue typing as discussed in the previous slide. For deceased donors, a donor is determined ineligible in the case of having HIV, infection, hepatitis, syphilis, vaccinia virus, West Nile infection, or sepsis. To get on a transplant list, a candidate must have an end-stage organ disease that no longer responds to traditional medical or surgical treatments. Each transplant facility has different criteria for organ transplantation due to the organ need. Candidates should have psychological and emotional stability, good family support, and stable financial support for the procedure and post-transplant care. No diseases that could attack the new organ should be present within the body. And it's important that they are looking at not only the family support, but also the financial support, as unfortunately the costs of medications and returning to the hospital is extensive with these patients. Recipient candidates typically have an age limit up to 60 years old. Rejection and infection. Post-transplant care involves constant balance among preventing organ rejection, preventing the risk of infection, and minimizing the side effects of immunosuppressant medications, which are drugs used to suppress the immune system, often to prevent rejection from a transplanted organ. When the immune system is suppressed with medication, the risk of organ rejection is minimized. Immunosuppressant medications increase susceptibility or decrease susceptibility to infection. If rejection is clinically suspected, it is confirmed with a biopsy. There are 3 types of rejection: hyperacute, acute, and chronic. Hyperacute is a type of rejection characterized by fever and anuria. It occurs in the first 48 hours. Signs can include generalized malaise, high fever, and anuria. Acute rejection is the most common form of rejection and is caused by primary allergenic response. It occurs in the first 6 to 90 days after transplantation. However, it can be detected 4 to 10 days after transplantation. It is a response to a foreign organ, and most patients experience some level of acute rejection. Treatment typically is a change in immunosuppressant medications. Chronic rejection is a rejection episode that occurs 2 or more months after transplantation and results in gradual and progressive deterioration of the organ graft. Chronic rejection leads to organ loss and is the only definitive treatment is transplantation. A 4th type of rejection is graft versus host disease. It begins 6 or more days after transplantation and is characterized by rash, fever, and severe diarrhea. It occurs when the donor organ forms antibodies that attack the recipient's tissues because it recognizes the host as a foreign body. After the transplant, there is a lifelong balance between preventing rejection and being at risk for infection. Signs and symptoms of infection include fever, cough, shortness of breath, sore throat, chills, sweating, fatigue, and gastrointestinal signs of nausea, vomiting, and diarrhea. There are 2 types of heart transplants. The heart transplant rate continues to gradually increase. There is a shortage of donor hearts. Therefore, transplant centers are increasingly using VADs, or ventricular assist devices, or total artificial hearts, as bridges to transplantation or as destination therapy in some cases. Hearts are the most used organ for transplants. Orthopedic heart transplants is the standard technique when the patient meets the criteria and a matched organ is available. In OHT, the recipient's heart is removed and the donor heart is inserted in the normal anatomical position. The patient is then connected to a cardiopulmonary bypass machine and the native heart is removed, and the donor heart is put in its anatomical place. Heterotopic heart transplant is a piggyback transplantation in which the native heart is left in place and the donor heart is attached to it. HHT may be used for patients with pulmonary hypertension, but has rarely been performed. So the most often performed one is OHT. Common diagnosis treated by heart transplantation includes cardiomyopathy, ischemic heart disease, coronary artery disease, valvular heart disease, congestive heart failure, and congenital heart diseases. Contraindications for a heart transplant include autoimmune disorders, irreversible kidney, liver, or lung disease, fixed pulmonary hypertension, and unresolved pulmonary infarction. Some relative contraindications include having COPD, being older than 65 years of age, and peptic ulcer disease. During a heart transplantation, a cardiac bypass machine maintains blood circulation throughout the body during surgery. Cardiac biopsies are performed on a prescribed schedule to monitor for rejection. It is imperative that occupational therapy practitioners adhere to strict hand-washing protocols due to the increased risk of infection. Additionally, sterile precautions are followed. As a reminder, this typically includes no lifting more than 10 pounds, avoidance of reaching backwards, no active bilateral shoulder flexion greater than 90 degrees, and no driving. During a heart transplant, the donor heart is denervated, so most of the pain that patients feel is typically related to that incisional site in their sternum. Because the donor heart is denervated, the autonomic nervous system no longer controls the patient's heart rate, and the patient's resting heart rate is typically elevated. Therefore, they require a warm-up and cool-down period to reduce the risk of fatigue and stress. Typically, the RPE is used to measure a patient's activity tolerance. In addition, therapists should pay close attention to the telemetry machine to monitor EKG for arrhythmias and monitor for signs of fatigue, dyspnea, and lightheadedness. Typically, when heart transplant patients are discharged, they will benefit from referral to an outpatient cardiac rehabilitation program. Just like with our breast cancer patients, how when a patient is discharging, we make sure that we have the referral in for a lymphedema therapist. It's really important that when these heart transplant patients are discharging, we make sure we put in that outpatient cardiac rehab referral so that they can immediately get started when appropriate at discharge. The lungs. There are 3 different types of lung transplantation. There's single lung transplant, which is the most common procedure and involves transplantation of the right or left cadaveric lung. Double lung transplant, in which the right and left lungs are transplanted. Commonly, this is used for patients who have cystic fibrosis or pulmonary hypertension. Living donor transplant is a very rare procedure in which a segment of the lung is intended for transplant. Post-transplant care includes short-term mechanical ventilation and supplemental oxygen, from which the patient is typically weaned before the patient is discharged from the hospital. Bronchopulmonary hygiene should be performed every 2 to 4 hours while the patient is awake. This includes coughing techniques, education and breathing techniques, including diaphragmatic breathing, suctioning for secretion management, vibration and gentle percussion, incentive spirometry, chest and upper extremity exercise, and postural drainage and positioning. With these patients, you're often going to be working very closely with the nurses and with the respiratory therapists. Occupational therapists should focus on increasing endurance and strength, incorporating proper breathing techniques, and facilitating engagement in meaningful tasks and routines. You want to check with the facility on their policy regarding thoracotomy precautions. Typically, patients will have restrictions for lifting of no more than 10 pounds. These patients are typically referred to an outpatient pulmonary rehabilitation program to increase strength and endurance for functional activities. Be sure to look at the chart on page 614 with the table 31.5 for more information. And just a reminder, like breast cancer and with the heart transplant patients, be sure to put in the outpatient pulmonary rehabilitation referral prior to these patients leaving the hospital, so there is no discontinuity in their care. So hand transplantation or hand allotransplantation has been performed more than 70 times around the world to restore sensation, function, and appearance in these patients. So 70 times around the world. It really isn't done that often, but it is an emerging procedure that can help patients who have an amputation and or no longer have use of that limb. Evidence has begun to favor transplantation over replantation or prosthesis. Reconstruction is typically performed in the following sequence: bone, vessels, tendons, nerves, and then skin. The majority of hand transplant procedures are performed at the wrist level and take 12 to 24 hours to complete. Occupational therapy is imperative pre- and post-operatively. Preoperatively, therapists will set goals, assess needs, take measurements, and begin education. Post-operatively, therapists should focus on hand protection, edema management, patient education, pain control, joint stiffness, prophylaxis, soft tissue adhesion prevention, tendon glide maintenance, motor re-education, and sensory education. Just think of all the tiny anatomical features of the hand and how precise it must be when they're doing the surgery. That's why it takes so long, and that's why therapy will need to be so intensive and monitored after the hand transplantation. As the wound heals, therapists will focus on increasing strength, flexibility, and function and preventing joint and soft tissue contractures. Historically, patients have been able to complete ADLs 1 year post-transplant and continue to show improvement in hand function even after 7 years post-transplant. So if you do decide to work in hand therapy and this is something that you encounter, it will be imperative that you work very closely with the surgeons on their postoperative care and what they allow for range of motion. Stem cell transplantation. Stem cell transplantation is a procedure that restores bone marrow function. Blood and marrow can be good sources for stem cells for transplantation. The purpose of stem cell transplantation is to return the patient's hematological and immune function to normal. Stem cells found in bone marrow develop into 3 types of blood cells: red blood cells, white blood cells, and platelets through differentiation. Different types of stem cell transplantation procedures include standard allogeneic stem cell transplantation, which is a close relationship between the donor and the recipient; reduced intensity allogeneic stem cell transplant, which is less intensive conditioning therapy is used to prepare the patient; autologous stem cell transplantation, where the patient's own stem cells are harvested from their bone marrow, blood, or frozen and then reinfused; synergetic stem cell transplant, which is the donor has an identical twin of the recipient; or cord blood stem cells. Stem cells are drained from the placenta or umbilical cord blood and frozen for later use. The most common diseases treated with stem cell transplantation are malignant disorders such as lymphoma, multiple myeloma, leukemia, immunodeficiency disorders, or malignant tumors from breast, testicular, or ovarian cancers. Occupational therapists will educate patients on fatigue management, orthostasis, and energy conservation strategies. It's important that with these patients, we're monitoring their vital signs, we're checking their blood counts in the chart and checking in with nurses, and we're minimizing the risk of infection. So making sure we're following standard precautions or neutropenic precautions, whatever the hospital requires. And we should note if there's any graft versus host disease symptoms. Patients are typically allowed to resume activities such as flossing, contact sports, heavy exercise, or sexual intercourse when their platelet levels reach an appropriate level. So for these patients, there will be a huge psychological impact. All patients are screened prior to transplantation. The screening focuses on promoting fair and equal access to care, wise use of scarce resources, identification of risk factors that could result in noncompliance, determination of cognitive and neuropsychiatric functioning, and treatment planning for any current psychiatric problems. These patients must have good coping skills and a strong support system. Research has shown that many pre-transplant issues continue well after transplant and can often lead to hospital readmissions, increased costs of care, and increased rates of infection. Many transplant recipients will have problems with fatigue, will be slow to return to their valued roles, will have difficulty adjusting to the new routines required to prevent rejection, will be slow to return to work, and will often have impaired social functioning. Graft success will depend on compliance with post-transplant regime, including taking all prescribed medications, lifestyle changes, including diet and exercise, avoiding substance abuse, and keeping up with follow-up appointments, particularly those to labs and for biopsies. It's important for therapists to screen for depressive disorders, anxiety disorders, and distress, because these are some of the most commonly reported psychological issues after transplant. So what are the implications for occupational therapy for these transplant patients? So the goals for therapy before and after are pretty similar. We want to just make sure that they're, 1, keeping their strength, and 2, that they're able to still engage in their activities of daily living as safely as possible. So the focus of therapy is on goal setting. We want to assess the patient for what their preferences are and what's most important to them. We want to identify educational, cultural, or language barriers. We want to focus on early mobility right after the transplant, getting them up as soon as is safely possible. We want to focus on strengthening, increasing their endurance, and obviously facilitation of participation in self-care skills. And then lastly, we just want to make sure that they're returning to engagement in their valued occupations and what's most important to them. While patients are on the transplant list, the goal is to keep patients as strong and healthy as possible, and as strong as healthy as possible because we have no idea how long they could be on that transplant list. Post-transplant interventions often need to be modified because patients remain deconditioned as a result of their organ disease. Therapy sessions will likely focus on minimizing the risk of infection, utilizing energy conservation strategies, managing stress, understanding the importance of exercise, diet, nutrition, weight control, and other lifestyle issues, stretching, warming up, and cooling down before activities, avoiding contact sports, waiting to drive a car until cleared by your doctor, avoiding lifting something too heavy until cleared by your doctor, protecting skin from sunburn, and self-monitoring using that RPE, rate of perceived exertion scale, looking at their blood pressure and signs and symptoms of metabolic syndrome. Occupational therapists are in a unique position to provide holistic treatment to transplant patients because of our increased understanding of body structures, the patient's functions, and understanding the transplant process and its sequelae. So go ahead and make sure that you've taken the quiz that applies to this lecture, and then go on and watch the second video when you're ready. Thanks so much.